Welcome to this penultimate panel here today on of the NASI 2015 conference on coverage over the lifespan. Good afternoon. My name is Renée Landers. Some of you who were here yesterday may have heard me a little bit at lunch talking about the Legal Writing Prize, but I'm on the NASI board and law professor at Suffolk Law School. I want to thank all of you for staying here at the conference into the afternoon. It's been a full day or more if you came for one of the interest group sessions yesterday morning or one of the roundtable discussions yesterday afternoon, where we've heard a lot of excellent thinking. Today so far we've had nearly a full day of interesting and stimulating ideas. But also, it's been a day that has commanded our attention and a prodigious amount of energy to stay, sort of engaged and focused on all the really great frameworks that we've been hearing about. We started the day thinking about the real accomplishments of the Medicare and Medicaid programs in improving access to healthcare services, and helping people manage the cost of those services. And then we moved on to consider how the changing characteristics of the population have implications for financing and delivery in the healthcare system. The adoption of the Affordable Care Act has extended some of the progress that we've made through Medicare and Medicaid and other innovations, but gaps remain because of affordability issues that we've also been talking about all day, and because some states have not adopted the Medicaid expansion as anticipated, but we'll get into more of that as the panel progresses. These successes and the challenge the country and us to think about the future of healthcare coverage and income supports using these programs aided by the Medicare and Medicaid and aided by the Affordable Care Act as a platform for continuing the work that's not yet finished. So this panel is going to address one of the problems with health coverage in the United States, to which many speakers at this conference have alluded, namely the fragmentation of coverage that fails to assure the continuity and coverage over a lifetime. When I was, during the last panel, just for fun, I Googled continuity and healthcare coverage, and two of the three quotes that Google produced were by Michael Porter. I just thought that was interesting since there were so many references to him during the last panel. And I hope not to preempt the speakers, but just to take the Medicaid program, for example, we have the CHIP program providing coverage for children, traditional Medicaid providing coverage for certain populations, and then thus, we have a situation where even in the one program, eligibility can change over time depending on income, age, parental status, or health status. The ACA attempted to eliminate some of this lack of continuity, but again, there was the Supreme Court decision sort of kept the patchwork, allowed the patchwork system to remain in place. On the private insurance side, a person may be covered by his or her parents' employer-based insurance now, thanks to the Affordable Care Act, through age 26, then transition to his or her own school or employment-based insurance, perhaps many times during a career, or purchasing insurance on an exchange, or maybe occasionally being eligible for Medicaid due to low income and this weak job market, as an earlier speaker mentioned, and then finally the transition to Medicare at age 65. All of these coverage possibilities could suffer from interruptions because of changing eligibility for the programs, inability to pay premiums, change in employment status, lack of access to providers, all those sorts of things that we've been talking about. They also may signal this level of fragmentation and coverage also is rather unique in the developed world, although I hate people who modify the word unique, so I apologize for that. While there's a growing literature about fragmentation and care in some of the countries providing universal coverage, Sweden is a country I'm familiar with because I teach there in the summers, so I hear a lot about what's going on there. And there's increasing fragmentation caused by migration within the European EU countries. This problem of coverage fragmentation is one of America's contributions to barriers in coverage throughout the lifespan. So while these transitions create problems, the relationship between the potential for improved health through improved coverage and access and the transitions in the population also suggest challenges and opportunities. This afternoon's panel will discuss some of the ways of addressing coverage over the lifespan. How do these structures address coverage for children, end-of-life care, long-term care, and every stage in between? Are public programs like Medicare or Medicaid or the exchange-based programs under the Affordable Care Act possible platforms or models for addressing continuity in coverage or care? What role are employers going to play in this matrix going forward? And what are the implications for health through the lifespan, which, after all, seems to be the point of providing health care and coverage? And what will be the impact of greater continuity of care on income security of the population over the lifespan? So I don't know if we'll get to all of these questions, but maybe some of them. We have an outstanding group of provocative thought leaders with us this afternoon to explore some of these issues from a variety of perspectives. As is the usual routine for this conference, the panelists will present their ideas for 12 to 15 minutes each, and the listeners are encouraged to write questions on the index cards that remain at the tables while the presentations are going on, so that by the time they finish that I will have a good stockpile of questions. Otherwise, I will have to wing it. I will then use the questions to try to engage the panelists in further exploration of the issues. You have more detailed biographies of our panelists on the program materials, so I will just briefly introduce them, but let their records and their ideas speak for themselves. The first speaker will be Dean Baker, who's the co-director of the Center for Economic and Policy Research. His remarks will be followed by Sherry Glied, who is the Dean and Professor of Public Service at the Wagner School of Public Service at New York University. And then last would be Douglas Holtz-Eakin, who is President of the American Action Forum. So with that, I'll turn the microphone over to Dean, who will start us off.
Thank you. See if I have my slideshow up here.
You can see it if you look straight.
Oh, yes, I do have the slideshow up. I'm sorry, I have to get in the habit. I need glasses for distance, and I'm still not, I still haven't realized I'm actually old enough I should be wearing my glasses all the time for things like this. But anyhow, thank you. Appreciate the opportunity to be here and be on this panel. I wanted to argue the case for universal Medicare. I realize that's a long shot now, but I want to try and argue, A, why I think it's a good idea, and then B, try to lay out at least what I hope is a plausible, or let's just say non-laughable story as how you get from here to there. And, I do know who's sitting in Congress, so I have noticed that. So, okay, thank you. Okay, so I want to make four main points. First off, that the current system has enormous waste in it, enormous waste in administrative cost, and these could be largely eliminated, or I should say, substantially reduced with the universal Medicare program. Secondly, that the track record indicates that both here in the United States and elsewhere, that's a far more effective way to reduce cost growth, which again, we've had slower cost growth in recent years. We all hope it will continue, but no one can say for sure. But the track record has been Medicare has been far more successful in controlling costs than the private insurers. Third is, suggesting how we get from here to there. And I'm going to talk about the idea, can you have a Medicare, Medicaid buy-in? I'm going to talk about that as a state-by-state or even region-by-region possibility. And the last one is something that I would encourage people to think about. It will sound crazy to people, perhaps, but I'd encourage people to think about the idea of increased trade with other countries, healthcare trade. Okay, first point, just, again, something I'm sure is familiar to people, just, it really is striking, I'm sure not to the audience here, but to many people, how much of an outlier the United States is in what we pay per person compared to other countries. This is from the OECD. It's a couple years old, but nothing's fundamentally changed. And Canada's the highest cost. I mean, obviously there's a longer list I could have put here, but Canada I think is number 2. Switzerland might be higher. But in any case, if you take an average of other wealthy countries, we're about twice the average. And if you take, UK obviously being a lower cost country, we're about 2.5 times per capita. And again, we could quibble, who has a better healthcare system, this and that, but the point is I'd say we're not qualitatively different. On some things clearly we're better, other things clearly not. So if someone at the end of the day wants to say U.S. is better, that's fine, but it's not leaps and bounds. We're not twice as good We certainly, no one could say that with a straight face. So clearly we're spending a lot of money and not getting anything for it, or not getting much for it, I'll just say, in terms of outcomes. Okay, at this point, I just love, in the context, I get involved in a lot of budget debates. I know Doug never talks about the budget. But in, a lot of debates, we hear all these stories about the long-term budget being out of control. And I always like to point out, well, when we talk about that, that really is a healthcare cost story. So very simple graph here. I just took the CBO projections. I think I might be a cycle behind. Obviously, they have their numbers that came out yesterday. But I took the CBO budget projections, and I said, suppose we plugged in Canadian healthcare cost rather than U.S. cost. And the story here is that instead of facing these deficits, which actually aren't all that huge, I have to say, but they aren't, instead of facing deficits, we'd have large surpluses. So we could say, or at least I would say, that when we talk about the U.S. having a budget problem, it is entirely a healthcare cost story. If we had healthcare costs that were remotely comparable to any other country, and keep in mind, Canada was towards the high end. I mean, if I could play games and put in UK, and boy, would we have a huge surplus. So when we look out and we think we have a budget story, we have a healthcare cost story. I think that's very straightforward. Okay, the next point, I'm not sure if that slide corresponds to what I have here. Does that say administrative costs as a percent of benefits?
No, annual rate.
Did I skip one? Oh, there we go. Okay, I'm sorry. I skipped one. Just the simple point. This is a crude comparison, and you could do a more careful one, but this is just taking a very, very simple comparison. If we looked at the administrative costs for Medicare, this is Part A, Part B, as a percent of benefits paid out each year, it's about 1.4%. For private insurers, it's 17.9%. Now, I'm saying this is crude. What others have done, doing more careful comparisons, one of the reasons why Medicare costs are low is we do have its administrative costs are low as a percentage of spending, is we have higher costs per person. So there's a lot of sort of per person cost. If you have a relatively young, healthy population, you're not paying that much in way of benefits, but you still have a lot of the same administrative cost. Medicare obviously has higher costs per person. You have older or sicker population. But even if you adjust for that, you would still have a very large difference. I've seen other analyses bring Medicare cost up to 6 or 7%, adjusting for differences. You still have very large differences. You're not going to make that go away. So you could reduce the size of the differences, but they're still very large. Okay, the next point, cost growth. This is taken from Center for Medicare and Medicaid Services. The last one, by the way, I was taking the numbers on administrative costs, just looking at Medicare's, the trustees' reports administrative cost, and the administrative cost for private insurers is taken from Center for Medicare and Medicaid Services. So this is looking at their own estimates, the Center for Medicare and Medicaid Services, of increase in cost growth. This goes back from the early 70s until, I forget the last year, 2011, 2012, thereabout, and a common benefit package. And it's, 7.5%, 9.1%, this is nominal, obviously. That might not seem that large, but you do the arithmetic, carry that out 20, 30 years, that is a huge, huge difference. Okay, so again, these aren't the most rigorous numbers in a sense. I'm sure one could quibble with them. They're not mine, the Center for Medicare and Medicaid Services. But the basic story here, I think, is pretty clear. Medicare has been far more successful in containing cost growth than private insurers. Okay, so question, what do you do about this? How, what's a plausible story? How do we get from here to a universal Medicare system if we say that is the better route to go? Well, one of the options that strikes me is if you had some sort of buy-in option, and this was debated, at the tail end of the, I shouldn't say tail end, it was debated all along with the Affordable Care Act, and there was a proposal on the table that I know Lieberman said he's blaming Jacob Hacker as all Jacob Hacker's fault, so I'll blame Jacob Hacker too. He supported it, so Lieberman said he's opposed to it. But, if you had an option for Medicare buy-in, and we're not going to get that nationally, clearly, at the moment at least. Obviously, with Congress as it is today, we're not going to get anything. But as a perhaps practical option that may not strike people as too scary, if you had some competition criteria, if you don't have 3, 4 insurers, whatever number you might pick in an area, if Medicare or Medicaid were given the opportunity to offer people a buy-in in that area. And again, that could be done at a state level, or obviously we have regions within states in the exchanges in principle, it could be done at that level. Hopefully that would not sound too threatening, and I like this idea in the sense that it's a market test. You're not requiring people to do it, you're giving them an option. And I'm saying Medicare, Medicaid. To my view, Medicare is much more preferred since it does have lower administrative costs, wider networks, other reasons I think people are well familiar with. The other issue is, could you have an age-based buy-in? And this was the specific proposal that Lieberman nixed, that, if we said that, you could buy in, whether it's 55, 60, but somewhere under 60, 65, the current age, giving people the option to buy in effect paying, the actuarial value for their insurance. So again, these are ideas that perhaps wouldn't sound too threatening, not requiring anyone, you're giving people an option compared to the existing system. The other route, Vermont, there was a lot of support. I gather there still is a lot of support for having a single-payer system at the state level. Of course, this is allowed in the Affordable Care Act. What happened was the governor backed away from it because it does require a lot of taxes. And this is, again, always the obstacle. I know I worked with a lot of members of Congress who are working on the 676 bill, the single-payer bill, prior to the Affordable Care Act being passed. And it was very difficult to get, members of Congress to agree. I mean, I wasn't telling them, I was just, giving them revenue options. None of them looked very good to them. So people don't like to raise taxes. I don't expect that to change. But, that would be a route if you had a single payer in, one state. May not be Vermont, but, one state, and that proves successful, that could set a path forward. Okay, the issue of trade, I've raised this and invariably gotten people very angry. There's three ways in which I could see how this could happen. One is to literally allow people to buy into other countries' programs. I'm thinking Medicare, that we pay however much. I don't know what the latest number is, probably around $8,000, $9,000 a year on average for a Medicare patient. If we said, okay, you could take this and use that to buy into Canada's system, buy into the UK system, and with the savings, let's say there's savings of $4,000, you split that. So this would give people an option. No one has to do it. The point would be it would save money, but to my view, more importantly, it would increase in familiarity with these other countries' systems. So I think that's, in principle, something people like the free market. They should love that. Secondly, facilitate medical travel, that a lot of insurers could save a lot of money by allowing people to have major medical procedures in other countries. India has a very good high-tech hospital system where they perform many procedures at, a fifth, even a tenth the price, which would allow massive savings even if you sent someone over, brought family members, had them stay a month, 2 months, why not allow that option? Why not facilitate that? In many cases, the issue is one of credentialing, establishing legal liability, should in principle be doable. The last thing, just to get down our cost and to weaken, to my view, a major obstacle to further reform is the doctors' lobby. If we brought in more foreign doctors, reduce the barriers. Again, we don't want to bring in bad doctors, but allow doctors who meet our standards, made it easier for them to come into the country. Again, I think that would make things easier for reform in the long term. So just to very quickly sum up, again, I have friends who've been working on single payer a long time who will probably want to shoot me for this, but, I don't see any way around it. I think the Affordable Care Act was an enormous step forward, and, I'm delighted that got through, and it was a great, great accomplishment. But, again, the U.S. still has healthcare costs that are out of line with the rest of the world, and if we could get those costs in line, our budget stories that so many people worry about would all go away. Thank you.
Okay, thank you very much. All right, let's see, where am I? Okay, if you've ever taught U.S. health policy, you know that the U.S. healthcare financing system is unbelievably complicated. It takes more than one lecture to get through it. Here's a picture of what our healthcare system looks like from someone who's relatively sympathetic to it. Here's one from somebody who's less sympathetic to it. Basically, this illustrates some of the challenges in our healthcare system, but I think it makes more sense to think about this problem not from this sort of meta perspective and in terms of formal complexity, but in terms of the actual lives of families. So I'm going to construct two families for you. I will confess right up that the numbers are not exactly precise and that I've constructed the families in order to illustrate my points. Bear with me. So this is the Smith family. You can't read it very well, but it doesn't really matter. They have a very chaotic situation. They live at about 200% of the federal poverty level. They have a 1-year-old baby, Abe. He's on Medicaid. Their daughter, Beth, is on CHIP. Mom's pregnant, so she's on Medicaid, and dad gets health insurance through his employer. So we have, for this family, 4 different spigots of money coming in, 4 different programs, 6 different spigots of money, because we have the federal government, the states, the Smiths, the employer, how did I get 6? The employer, I have it written down here, the tax treatment of health insurance, maybe that's 5, I can't count. So lots and lots of different money coming in here, and they are paying at this point $1,420 on premiums for this family, which comprises about 3% of their income, and they face a couple of $1,000s in potential out-of-pocket costs. Then we have Grandma and Grandpa Smith. They're on the bottom there. Grandma's retired, and she's in a marketplace plan, and Grandpa is on Medicare. Between them, they face premiums of about $3,500, which comes to about 12% of their income on premiums, and they face a potential out-of-pocket burden of $9,000. So very different situations for these 2 families, both at about 200% of income. One of them is scattered among the 4 wins. The other ones are scattered in 2 different programs, and they face different cost sharing, different deductibles, different premiums in all of those situations. Now let's look at the Smith family 4 years later. Abe and his sister and the young baby Cora, I couldn't get her on the slide, it's small enough already, are now all in CHIP. Mom is working part-time, and she's covered by dad's plan. Let's just assume all of this. Between all of these things, Grandma's retired, has now hit 65, so she's on Medicare. Between all these things, this family's premium has actually gone up to 7% of their income, and they also face about $4,000 in out-of-pocket expenditures. And Grandma and Grandpa are actually much worse off than they used to be. They're now facing premiums of 14% of their income, and out-of-pocket expenditures as high as potentially 1/3 of their income. So even though they've both reached Medicare age, they're actually worse off than they were when Grandma was in the marketplace. And let's contrast them with the Jones family. It's a more prosperous family. They make about 5 times the poverty level. They are all covered by one insurance plan through their employer, and Grandma and Grandpa are still on Medicare. The older part of the family is paying about $4,800 in premiums, which comes to just about 4% of their income. And Grandma and Grandpa are paying exactly the same premium as the Smiths were, but for them it's only 5% of their income. So this, I think, is sort of an illustration of how kooky the American healthcare system is if you're actually in it. So what are the problems that you then face? So problems of fragmentation that we talk about all the time: continuity of care, incentives for prevention, and 3 more that I really want to talk about: time-consuming applications, choice of plans, and unpredictable financial demands. So think about within the family. We have different providers for different members of the family because they're all likely to be in different provider networks. That's something that we talk about a little bit aspirationally. It would be great if everybody were being seen by similar providers. You can imagine that mental health care, for example, would be better if mom and the child were seen by were in the same network. Realistically, we don't know that it matters very much for all the members of the family to be scattered among providers. But there certainly is a lot of churning and a lot of keeping up with all these providers within and across time. A second set of problems is delivery discontinuities. We think a lot about people keeping their primary care doctor, and that's definitely a concern, but of course this fragmentation also means that you might be seeing different specialists. Your drugs might change as you move from one plan to another, and even though we've made big investments in electronic health records, those probably don't move with you as you move from one plan to the next, especially if you have to change providers on the way. Economists worry a lot about these incomplete incentives for investment in prevention that come from having all these different spigots of money that are all paying in. So why should the states care about what you look like when you get on Medicare? Why should your employer invest in prevention if you're going to switch to another employer? I think we talk about this a lot. I'm not sure that the evidence is actually there that this makes an enormous difference. I think it's much more of a concern in theory than it is in practice. Of more concern, I think, are the problems of enrollment, choice, and financing. So this family faces different enrollment and coverage processes for every single person. And if you imagine how you have to actually do this, the complexities of doing it are going to be quite high. And there's some evidence from Dubé and Kenny in the CHIP program that just having people in lots of different programs reduces the propensity of people to sign up. And that's particularly true if you think about the non-employer programs. Think about how you get coverage in Medicare. Grandma and Grandpa basically don't have to do anything for their coverage. It comes to them. If you think about employer-sponsored insurance, somebody actually comes to your door and says, Can you please sign up for health insurance? Sign up now. The deadline is tomorrow. How many emails did you get this time on your open enrollment period, right? And everyone knows exactly where to find you. But if you're in Medicaid or the marketplace, first you have to realize that you can be in health insurance. You have to get an application. You have to fill it out. You have to qualify. You have to choose a plan. And then you have to make regular premium payments or you're going to be disqualified. All of that nearly automatic for the folks who are in Medicare and ESI. And all of this is confounded by the fact that somebody has to choose which plan to be in. And I think it's really important to remember that the whole basis of our system, the reason we think it works, is we think people are making powerful choices. We've talked about that just in the last session about providers, that people are going to make choices about provider quality and so on. So if you look at the literature on choice in families, it turns out mom is usually the one who does these choices. And think about this mom in the Smith family. She's going to have to pick a plan, a provider, for each one of the members of her family separately, potentially 6 different sets of health insurance choices, which I think is pretty awful. So for a moderate income family, simply the burden of making choices is going to be very challenging. And then what about the financing of this? How much should this family pay for premiums and cost sharing over time? Should the Smiths be paying 3% of their income or 7% of their income? They are, in one year they pay 3%, and the following year they pay 7% because one of the babies just grew up out of Medicaid and into CHIP, and mom left Medicaid and wound up on her husband's coverage. When they're elderly, should they be paying 12% of income or 14% of income? Should the Joneses and the Smiths be paying the same amount of premium for Medicare, even though for one of them it's 14% of their income, and for the other it's 5% of their income? How much cost sharing can a family bear, and does the choice of plan you're in determine how much cost sharing you can bear? So this is a tremendous mess, I think, on these particularly important grounds. So what should we do? Do we need a rational healthcare system? No. Okay? I want to paraphrase Barry Goldwater. Elegance in the pursuit of health policy is no virtue. The purpose here is not to make something we can explain to our students. It's to make something that works as well as possible for these families and that we can actually accomplish. And I think it is important to think about how much political and health system discombobulation has accompanied the Affordable Care Act, which at the end of the day will affect something like 7, 8, 10% of the American population. So a relatively small program in those terms. Medicare the same way. It affected about 8% of the population when it was first enacted. And look at all the Sturm and Drang it brings us. So thinking about major changes in the US healthcare system may not be the way to go. Maybe instead we can focus on what really matters for these families. How much can a family afford to pay for health insurance? Can we come up with some guidelines around that that would be consistent across programs and over time? How much can a family pay at the point of service? How many choices can a family make efficiently? Is it reasonable to be building a system in which we have that many choices for people to make? And then is care continuous? Are records portable? What can we do around these very micro changes in people's health insurance? I want to suggest thinking about two areas where I think we could make some difference. One is to think about continuity. Can we work with our existing programs to provide incentives for plans to offer consistent provider networks across the different markets in which they operate? So at least if a family chose one plan, they could choose the same plan no matter which one network, they could choose the same network no matter which insurance plan they were enrolled in. So can we imagine offering Network A, which is offered in Medicaid, in CHIP, and in Medicare, and whatever? Second, could we develop some incentives for easier portability of electronic health records so that people can actually move their record as they move among providers? Maybe it doesn't matter so much whether you keep the same provider if your records go with you. So let's think about some micro policy changes that we could make to approach continuity. And then let's also think about affordability. This graph, which is a little bit complicated, the red line in the graph shows the portion of people's income that they're expected to pay for health insurance under Medicare. You can see that it's flat up to about 100% of poverty, and then it goes up steeply, and then it increases from there on. And the other piece is the amount you're expected to pay for health insurance under the Affordable Care Act, which rises because your share of premium is not fixed as a share of income. And you can see that, especially at the bottom, there are about 5 million people who are expected to pay much less when they are under the Affordable Care Act in the marketplaces than if they were on Medicare. So there's actually a lot of people now who, when they age into Medicare from the marketplaces, will wind up paying much, much more for health insurance. That's actually something that I think we could focus on. So some small fixes around affordability. And let me just stop there.
So I'm at a tremendous visual disadvantage because I don't PowerPoint. I did one, my very first one I did in front of the President of the United States, and it contained an error. And he threw me out of the West Wing, and so I gave up slides for life. So I'm going to just talk to you about this issue. I think this is really important, this notion of the fragmentation and the gaps in coverage and care over the course of lifetimes and across jobs and home. And as Sherry has made clear, we're not going to come instantly to some elegant, rational solution. We're going to have these kinds of issues. And so the way I think about it is it seems pretty clear that this is going to have to change. And then I ask myself, what is it that's going to cause our policymakers to change things? And so I think it's useful to just recognize the forces that drive this. And number one, which Dean forecast, is we have these budgetary issues. And I don't think we can ignore the fact that in what the CBO put out just 2 days ago, 10 years from now, we've got a $1 trillion deficit, and $800 billion of that $1 trillion is interest on previous borrowing. And so we are, as a nation, if we stay on autopilot in the absence of change, we will be borrowing just to pay interest on previous borrowing very quickly. And politically, that means the next president, who is elected in 2016, will want to be governing in 2024 when this magic moment arrives. That means that something's going to have to be done. Maybe we won't fix everything, but something's going to have to happen over the course of those 2 terms. It strikes me as politically unwise for the president to surprise us with a big change in our social safety net, so they may want to actually talk about it in the campaign. And so there's both political and budgetary forces that are going to say we have to change the way some of these programs work. And thinking about those forces, I think, is important. It's also clear we have some insurance design issues. Medicare doesn't look like a policy design that you would create in 2015. It's a legacy of a different era as a major medical program that no longer matches the demographic and healthcare needs of the population it serves very well. So there's some design issues that are going to drive changes because the population's going to continue to age and to have multiple chronic conditions and constitute both more and more minorities, and their health needs will be different. So that's going to be driving things. And then we have the ongoing struggle with delivery system reform and care delivery in the United States, which are simultaneously going to impede on this. So we've got a real impetus for change, and it's coming from a variety of sources. And the question is, can we direct those in a good way and reduce the fragmentation and help coverage over the life cycle, or will we not? And I think that's the way to think about this. I don't think of this as let's write down a magic plan and go from A to B. It's, we have guerrilla warfare on coverage fragmentation from now to 2050. Let's be ready for all engagements and see what they look like. How do we do that? I mean, I think over the near term, there's a couple that are going to play out pretty predictably. To my eye, if you look at Medicare, we'll do something on fee-for-service to integrate A and B deductibles and things like that, make the design better. But the real bridge to the future in Medicare is Medicare Advantage, which is not perfect by any means, and there are good and bad MA plans, but MA is where we have learned to do care coordination. It's where the ACOs are going to learn to do care coordination. It's the bridge to the future in Medicare, and right now it may not be adequately financed, and there are going to have to be some efforts to shore that up. And then the next step is going to be, okay, let's run the test. Let's let fee-for-service compete with Medicare Advantage in some sort of bidding and see where people want to go. But that's going to be something that I think is going to be central over the near term. The second thing that's going to happen, I think, over the relatively near term is the integration of the Medicaid populations and the exchange populations. I think Sherry's description of sort of what goes on at the household level is exactly right. It's also true that people bounce across these lines far too often, and they move into Medicaid, and then they bounce back up to the exchange, and they get a different policy and a different provider network, and it's bad for care, and it's going to be hard for states to run, and there are good reasons why the exchanges should be used more extensively. We need to have good insurance markets in the United States, and these are a starting point for better insurance markets. So I can see that being a pressure as well, sort of coordinating those populations a little bit better, not having them bounce around quite so much. Over the longer term, the central question that will have to be decided is whether we look at these programs, Medicare in particular, Medicaid, as defined contribution or defined benefit plans. And that is a decision about which we simply have not come to resolution. I think the answer is quite likely going to be a defined contribution plan for a couple of reasons. Number one, the budgetary imperatives, if we don't deal with these healthcare costs, Dean's right about the driver, the budgetary imperatives will make it easy to, quote, solve the problem by just saying, hey, we're not going to spend any more money. I'm not saying that's a real solution, but we've seen this movie before, DC, and that's going to be a tempting solution. And so that the budgetary piece pushes you that way. There's also a more important thing, which is I don't know what the benefits will be 5, 10, 15 years ago, or years in the future. If you think about what's going on in the old age population, there are a lot of things that we might now think of as long-term care services that I think probably should be delivered in the home at the same time we're providing home-based care to Medicare beneficiaries, and that this arbitrary distinction between long-term care and Medicare probably doesn't make a lot of sense. And you could easily imagine all sorts of technological revolutions that we can't even imagine that we're going to have to put into these policies. And the DC framework is far more flexible because we don't have to anticipate what it is that we want to put in the benefit package and what it is that is the best place to deliver it and all those things. And so I think from an innovation point of view, something that looks more like a defined contribution plan makes a lot of sense. There's also room there for a nice political trade, which I think is overdue, which is you can then take nursing homes out of Medicaid, put them in the federal government's budget, let the states take care of the Medicaid populations integrated into their exchange populations, and we'll have a system that might not be rational, but I think will be more rational, Sherry, and where we can then sort of deal with the old age issues in a unified fashion and get that right to the extent possible. If you have that kind of a framework, then it's far easier to deal with what I view as the major portability issue that we face right now, which is portability from work to retirement. The issue of how we're going to cover somebody till they hit Medicare eligibility is an issue, and if you could carry an employer policy and turn it into that same defined contribution in a Medicare program, we could make a lot of progress on that issue in portability. And so that would get us a lot better in coverage over the life cycle if we had a framework that allowed our employer contribution to be transformed into a contribution at the federal level. And that might not be perfect, but I think that would improve the possibilities enormously. The one thing that's been missing in all this, the 800-pound gorilla, is the future of employer-sponsored insurance in the United States. If you were starting from scratch, we wouldn't do it this way. And as someone who designed what I thought was incredibly clever, 100% right, but politically unsaleable reform plan that basically got rid of employer-sponsored insurance, I've come to appreciate how nervous people are about upsetting the employer system. And so figuring out where it goes, I think, is an issue. I can imagine two possible futures that give us better lifetime coverage and less fragmentation. One is a regulatory change that basically says, if you get a policy at the age of 26, when you can leave your parents, say, and you maintain continuous coverage of any sort, individual, small group, large group, whatever it might be, you may not be medically underwritten, ever. And what that would do is allow you to really price in effectively the pre-existing condition problem. You force insurers to look over life cycles and deal with how people evolve, and you don't get the fragmentation in coverage. So you get some care improvements and you get some insurance improvements. The second one, which I worry about a lot, is the possibility that insurers or employers are just going to get out of the business of doing health insurance because of the ACA subsidies out there in the exchange. I've done this arithmetic a number of times. It is pretty unassailable that up to about 250, maybe 300% of the federal poverty line, you can get out of the insurance business, pay the penalties, give your employees raises. They can take their after-tax raises and the subsidies and buy insurance that is just as good as what you are offering, and the employer still ends up ahead. The only problem there is the taxpayers picking up this check. The subsidies on the table are that generous, but that's a way in which we now migrate an enormous amount of what is employer coverage into this large exchange pool, and that's a reason to look at the exchanges and design them carefully. They have a place picking up what may have been the employer population. They have a place picking up what used to be the Medicaid population. And I think a lot of attention on the future of exchange-like mechanisms is at the heart of fixing a lot of this fragmentation. Thank you.
That's great. So we have a few questions up here, and I think there's some more in the back. I saw another hand wave. Lots of hands wave. So one question I have was for Dean, which was about the importing of foreign doctors. Just to start there, isn't that really poaching from health systems that need the talent and the capacity more than we do? And isn't the answer really to build our own capacity within? I mean, the Ebola crisis sort of illuminated some of the weaknesses in the structures of the other healthcare systems.
Well, I'm going to play economist here. You know,
Yeah.
economists love trade in all circumstances except when it hurts people like them. You know, no, for the same reason that countries that export food don't go hungry. Doctors are not in fixed supply, and the reality is it's much cheaper to educate doctors in other countries than the United States. So if we were a good economist here, we would say, let's import more doctors. We could pay them. We could pay them to educate 2 or 3 doctors for everyone comes here and still come out way, way ahead. The differences are so stark. I mean, I'm comparing the U.S. to West Europe. I'm not even talking about
Right.
U.S. versus
Right.
India or, you know, the developing world. So, you know, that would be the efficient outcome. So by all means, I would say, yes, we could have more doctors, and they would have more doctors too.
Okay. Any other comments on that question? Yeah. Yeah. Right.
But we could import much more.
We could import more. Yeah, no, I'm with you.
All right, good.
So I think,
Yeah.
I think the more general point is, you know, when I think about the next round of near-term healthcare reform, I think it's going to be in the states, and it's going to have everything to do with things like the scope of practice restrictions and which kinds of providers can deliver which services and certificates of need for facilities, things like that. There's a lot of anti-competitive things on the ground out there that keep healthcare expensive in the United States. We need to address them all.
So one thing is to make law degrees, medical degrees, undergraduate degrees like they are in other parts of the world and not have this huge investment. Yeah, no, I know. I'm with you. I share some skepticism, but it is one thing that makes the production so expensive. Okay, let's see. Dean has a lot of questions, but gosh, goodness. Okay, for Doug, it says that you did not address the issue of the significant portion of the Medicare beneficiaries who really cannot afford Medicare. Folks above 100% of the federal poverty level only get some assistance with Part B premiums and can't afford cost sharing. Wouldn't defined contribution make it worse?
Well, I mean, the defined contribution should and I would expect would be adjusted for both resources, you know, income, and for insurability. I mean, people who are sick and have low incomes are going to need a much bigger support. People who are healthy and relatively high income get a lot less support. I think you have to just build that into the system design.
Any other people want to comment? My panelists want to comment on that one?
I mean, to me, defined contribution is basically getting away from insurance. I mean, I don't really see how you could design it and still have insurance as we think of it today. I mean, we could obviously save money by not paying for a lot of things, but I don't think we're giving people insurance then.
I mean, you know, the thing about the
You're
defined
giving them support to buy insurance. It doesn't get rid of insurance.
I think the challenge in the defined contribution model is that the underlying assumption is that a lot of the cost of health care can be controlled by the managed care companies on their own or by the individuals on their own. Since the evidence suggests that most of the differential between U.S. and foreign healthcare costs is in the prices that we pay to intermediate inputs, it's much harder to make the argument that that those managed care plans can actually save money. And if they can't, then costs will continue to rise as they have anyway, and all we will have done is shift the burden of unexpected and very large healthcare costs from the federal government to individual families, which from a risk-bearing perspective seems like a really bad idea.
So how much, there's been a lot of talk today about skin in the game. I'll just ask a follow-up question. How much is it fair to expect people to put skin in the game? Or is just their health being at risk enough skin in the game already, literally?
We know that, I mean, this is one of the things that we know pretty well. We know what the effect of having skin in the game is on healthcare spending. And we know, and I would say that at this point, most people in the U.S. have healthcare plans outside the Medicaid population, in which they have quite a bit of skin in the game already. It's not clear. The evidence does not suggest that moving from the level of cost sharing we have now to a somewhat higher level of cost sharing is going to have dramatic effects on our healthcare costs.
So I guess the thing that I find frustrating about the current debate, it comes back to this issue of affordability. And if we're spending 16, 17% of our national income on healthcare, that's what's affordable. That's how much we're spending. You can't say everyone's going to spend 10% because it doesn't add up. So we have to have an honest and realistic discussion about where the money is going to come from and what constitutes realistic, affordable. The other thing we tend to do is to treat all healthcare as the same, and it's not. There's an enormous range of acute versus preventive or chronic. There's lots of elective, and there's things that you absolutely have to have, and the cost sharing should differ in those circumstances. There isn't a right way to do it for everything, and that's a mistake that gets made a lot by the policymakers.
To pick up on Sherry's point, I mean, again, what do we hope to save with cost sharing? We know the vast majority of our spending is going on a relatively small number of people with very high expenses, and most of those, by any sort of remotely reasonable means test, those people can't afford it. I mean, we don't have that many people who could afford hundreds of thousands a year for care. So, the skin in the game story, okay, we have people, we're talking about people with relatively low levels of expenditure, and maybe we could lower that a little bit here and there. Again, we already have a lot of that. Maybe you could lower that a little bit more. That's not going to have a big impact on costs.
Just one more follow-up on this point, and then I'll move on to the other questions here. There was a lot of talk earlier today about, getting control on the cost side as opposed to, sort of tinkering on the payment side. What about that? Do you have any comments on that, or do you have any reaction to those proposals? Price regulation, that sort of thing.
I think there's a lot of things we could do on the cost side. I mean, it's beating up on doctors, but I mean, drug companies. I mean, I think there's a lot about our healthcare system that's an absolute mess. And I realize this might seem far afield, but the reason we have expensive drugs is because of our patent system was supporting financing drug research. If we had an alternative mechanism for financing drug research and had drugs sold at their market price, we'd be saving, tens of billions, perhaps hundreds of billions a year. Same with medical equipment. I mean, you face absurd choices because of the way in which we finance research. The idea, should we pay $84,000 a year to give a hepatitis C patient Sovaldi? I mean, that's okay. Is that a tough choice? Maybe yes, maybe no. But if they could get generic Sovaldi for $1,000 a year, which is the price in India, high-quality generics, that's a no-brainer. So we create problems for ourselves that are very difficult to solve because we have an incredibly backward way of financing research.
All right. So there are a couple of questions about the globalization approach to things. One question was, how do you safeguard or address the issues of quality and safety within the context of trade? And then another aspect of that, a variation on that question, is with the exception of elective surgery, how would you go start buying into another country's healthcare system? How would that work logistically? For emergencies, preventive care, how does that work?
Well, in terms of quality, I mean, we'd have same sorts of quality control we have now. The point would be just to make it as easy as possible for foreign doctors to train to our standards. Back in the 90s, we cut in half the number of foreign medical residents that came into the country each year. It wasn't because we thought they were incompetent. There were no stories, at least none that I heard in the debate, that we had, incompetent foreign medical residents coming here. It was they wanted to reduce the supply of doctors. Well, let's double it rather than cut it in half. So we maintain our standards, and we do this all the time in other areas of trade. We go, okay, we're going to have international standards. We'll sit down, we'll agree with them, with Europe, with the other trading partners, and everyone who meets those standards, they could come here. So I don't see that as some big insoluble problem. The other question, suppose we said, I'm buying into Canada.
Can I just say, I mean, I thought the question meant more about, what about sending, buying into Canada. You're going to
you were asking about people going to other countries. Okay, no, that's a very good thing, very good question.
Yeah.
Again, that's one of the big obstacles. If we had some sort of accreditation system, and I realize they're private ones, but if we had some sort of governmental, whether it's international or U.S., whichever it might be, so that people would know that if they're going to a hospital in India, they're going to one that meets our standards. So that's why I think it's a big obstacle that discourages people from doing that today, both individually or if they have insurance. So I think that would be a really important thing, to have some sort of accreditation system where we could evaluate those hospitals so people could say, okay, these are our top class facilities. So I think that would be a really big step forward.
I'm always amused by this idea that we will be sending all these people to India because we already know that there are twofold variations in the cost of healthcare within the United States. So a reasonable question is, why don't insurers in New York City just send people to Minnesota? I mean, they don't have to send them to India. They could just send them to Minnesota. And they don't do that. I don't know anyone who crosses state lines, even though they could.
Well, that's practically Canada. I mean,
it is practically Canada, I suppose. You know, so I think that we...
Well, bigger differences mean more incentives.
But these are, I mean, from the
No, I
insurance
know they're
company's
large,
perspective,
but you'd
they
have
don't,
even bigger ones.
you know, everyone speaks the same language, they're the same culture. We don't do a lot of this. People want to get health care near home. In fact, part of the reason our healthcare costs are so high is that we are so committed to the idea that people should be able to get health care near home, that we put a lot of money into rural hospitals, for example. And we have a lot of small hospitals that cost a lot of money. So there are many things we could do if we wanted to encourage people to not get health care near home. There are many savings we could generate.
So just you were going to answer the question about the buy-in part.
Oh, the buy-in,
yeah.
So to take that case, suppose I bought into the Canadian Medicare system, then I would be, I would have the option either to move to Canada, or I would have the option, to get, pay for, normal expenses. Well, I actually like Canada, so I might do that. But
It might make sense if you live on the border of Canada.
Yeah, and I could get care there. I could pay for, sort of minor, day-to-day checkup or something out of pocket, and, for any sort of major procedure, get care in Canada. But being a little more, being serious about this, a lot of people do actually have friends, relatives in other countries. That's not that strange. I suspect a lot of people here do. So the idea that you might actually want to live in another country and put $5,000 in your pocket every year from what you've saved on Medicare, I don't think that sounds so far out. If people, and the other thing is, if it sounds far out, you don't have to worry about it because no one will do it.
So as a Canadian, the only concern I have about this is, why would the government of Canada, which is
Right,
already
exactly.
concerned about making
Charge
sure
a
that they have,
10% premium.
they'd have to charge I think they would want to charge
15%,
quite a substantial
whatever.
premium. It may not, and they may not want to do it. For example, on the drug side, I think they would be very concerned that they would lose their bargaining clout with pharmaceutical companies if they began to draw off the lucrative U.S. market. So, if you're thinking about trade, there are two sides to trade agreements.
Okay. All right. So this is another set of questions about, the Medicare as a platform. One question is, supporters of Medicare for All say it's the simplest way to achieve universal coverage at universal peace of mind. Why?
Well,
Say the question, sorry.
Oh, no, it's okay. Supporters of Medicare for All say it's the simplest way to achieve universal coverage at universal peace of mind. Why?
Okay.
well, I think the argument would be that having a single system that people were in, over their whole lifetime that covered the bulk of their medical expenses would be, to my view, a great thing. But getting from here to there, I'd have to say, is not a simple process.
So I wanted to ask you, when you were talking, there was a program yesterday on, health policy where people were talking about, sort of phasing in, Medicare as kind of the universal option. And there was discussion about whether it would be better to kind of expand it gradually from the bottom up. So, add children, then teens, then, young adults, et cetera, or from the 65 down, decade by decade over a period of time. What do you think about those approaches? Or is it all one fell swoop, the right answer?
Oh, I think one fell swoop's impossible. I mean,
Yeah.
And whether you go bottom up or top down or age down, I don't know what the term is, I'd just say it's purely a political issue. I mean, I don't think there is an advantage that, if people are going into Medicare eventually, then it's easier to say, okay, let's make it 60 rather than 65. But is that easier to do politically than take children, many of whom are already covered under Medicaid S-chip? That I don't have a simple, that ends up being a political call, and I wouldn't be able to say which one ends up being easier.
Any other comments on that one?
I refuse to aid and abet this scheme. It's not a good idea.
We'll get to you later. There are some other questions for you. Okay, then what about a Medicare Part D model system for all? Medicare plus private populations, if I'm reading this right, get some plans with subsidies by income.
That's
Did
my
I read that
plan.
question correctly?
That's
Yeah.
the spirit of my plan.
Okay.
And, to my eye, Medicare Part D is our best functioning entitlement program, and we should replicate it to the extent we can elsewhere. it's important to recognize that it won't replicate exactly. I mean, one of the great advantages of Part D is it's a commodity. It's a nationally traded commodity, and so it's easier than that. It's not like the rural hospital, which is different. And so, you can't just wholesale import the whole design. But it is worth thinking hard about the fact that the program is quite popular, has come in below costs, my fault, estimated too high, and really, has met the needs of seniors for an important part of modern medical therapies. And, that track record, I think, should not be dismissed when we think about the future of the rest of Medicare.
Can I ask you, Doug, how you see this different from the exchanges? Do you have any
So the exchanges are a platform for insurance policies broadly. I mean, this is a narrow, the drug benefit, and they have a lot of similarities in terms of their competitive structure and things, all of which I like. I mean, I don't feel like we have to pick between them.
So there's one question about exchanges. If exchanges are important, how do you keep them affordable if the Supreme Court rules against the subsidies and the federal operated exchanges?
So there are two different things. One is the exchanges themselves, marketplaces where people can shop for insurance products, and they serve that function. They have an information function in delivering information about what the options are. They have a shopping function. They can also be conduits for value, right? And we do that because we use them as conduits for the subsidies. But the virtue of exchanges per se is not because they get the federal money. I think they have virtues in and of themselves, and I want to see them strengthened over time. Obviously, we had this conversation before the panel started. If they strike down the subsidies in King versus Burwell, somehow you have to keep the money flowing. You can't just turn it off. That's the technical term for that is madness. And the question is how. And I thought I had these have all these clever fixes in my head that people keep telling me are illegal and things like that. I thought the CMS should just sell every state in exchange for $1, and then everyone has a state exchange, and off you go. We're done. Turns out you can't do that. I didn't know why. I still can't figure out. It's not legal. Yeah. Who's going to sue? That's the other thing you say. All right, who is standing to sue? I don't know. Anyway, but yeah, probably.
Yes.
But at any rate, I mean, there has to be some, a full expression of the backup plans administratively. What can you do? And then, the Congress should be prepared to pass legislation that says extend the current subsidies to any type of exchange through date X. And if they want to make changes after date X, then they should, pass legislation with a different set of subsidies. That's a fair debate to have. But the first step's the important one.
I just want to say something quickly on exchanges, because I think both of you made comments that I take a little issue in terms of the number of people on the exchanges. I think it's important to keep in mind that a huge number of people go on and off. I mean, 4.5 million people leave their job every month.
Yes.
And, so that translates into a lot of people presumably going into the exchanges and going off. So the number of people who are going to use the exchanges over the course of, say, a 2-year period is vastly more than the number who will be there at a point in time.
There are some statistics on the total number of people who touched the exchanges last year. But you're right, there will be a lot more.
Sure will.
So, anyway, but arguably that fix, that legislative fix, is something that could have happened in a technical correction bill as soon as people realized that there was this problem, assuming a different set of political parameters than we're operating under right now.
I would like to assume I'm 6'4" and have a full head of hair. I mean, it ain't so.
This is, I think, that'd be a very, if the court decision goes the way where they say that, these aren't, the subsidies aren't allowed in the federal exchanges, to my view, it'll be important that the Obama administration stands firm and says, look, this is unfortunate, and hopefully the states that don't have exchanges will set them up very quickly, because it's obviously a disastrous situation for the people in those states losing their subsidies, and hopefully reason will prevail, as Doug says. But I think it would be important for the Obama administration to stand firm and say, okay, we're not going to scrap the Affordable Care Act now.
So, but why would states who've been so adamantly opposed to operating their own exchanges or adopting the Medicaid expansion, why would they do that? They now would see affirmance from the Supreme Court.
Well, I think two things. One is you do have the industry groups in those states don't want to lose the money, and the other is that they are talking about a lot of people. It's one thing to not give care for Medicaid. Lower income people by definition. These are middle income people, so it's you're telling a lot of middle income people, okay, you're not going to be able to afford your health care. So that I think is a much bigger deal.
I think the politics of taking away money that people are receiving are different than the politics of not giving people money they haven't seen.
Okay, that's a fair point. Okay, so why is decoupling employment from health insurance a bad thing?
It's a really good thing.
Yeah.
I don't think it's a good thing.
Yeah. And why are we worried that employers will drop ESI? So those are two questions. Yes, go for it.
So I would say the robustness of employer-sponsored insurance worldwide is an astonishing thing. Even in countries that have universal health insurance, employers are heavily involved in providing supplemental benefits. In almost every country, the Netherlands has worked really hard in Switzerland to push employers out of the system. It doesn't happen automatically. It actually takes effort to actually get rid of employer-sponsored insurance, even when there are no tax subsidies and nothing else going with it. It's a very robust institution. We as economists tend to think in very broad theoretical terms, but when you actually look on the ground, I think we ought to be a little wary about what we see, because there are very few institutions that have been as robust for such a long time as employer-sponsored insurance in firms with over 100 employees. Hasn't been going anywhere. Healthcare costs have gone up. There was a lot of talk over the last 20 years about moving to a defined contribution model. It has not happened. There are going to be these private exchanges. They've disappeared. Employer-sponsored insurance seems to be something that, for some reason, people really like.
So you've written something, Sherry, about how the employer group is kind of really the only community group, affiliation group, right, that allows people to aggregate and therefore purchase insurance. I mean, is that part of your
So part of it is that adverse
analysis?
selection is a huge problem in insurance markets. It's just an enormous problem in insurance markets. We see it all over Medicare Advantage. We worry about it terribly in the exchanges. The only institution that has been able to avoid adverse selection in a significant way is employers. You have very little adverse selection within employer groups, and that is actually a really important thing. If we had some other way, Medicare works. I mean, if you put everybody in a single plan, you're okay. But if you don't want to put everyone in a single plan, the best thing we've come up with so far has been employer-sponsored insurance. Now, you know, the Netherlands and Switzerland are, and to some extent Germany, are working it out without that. But it takes an incredible technocratic effort to keep it going without that institution.
So,
Yeah.
you know, the thing that I mentioned in my opening remarks that I'm worried about is we essentially have this competition right now between these two big subsidies, right? We have the non-taxation of employer-sponsored insurance as a subsidy to affluent Americans, those who get the bigger insurance policies, have higher marginal tax rates, they have bigger subsidies, and now we have these direct subsidies available to lower-income Americans in the exchanges. And in between are pinned the employers. And the employers could easily say, I'd like to get out of this business and send these guys off the exchanges, but my high-income and high-wage workers want the insurance, and because I can't discriminate, I'm going to hold on to all of them. And we just have these two big public subsidies competing with one another. So if what Sherry says is right, we could get rid of the non-taxation employer-sponsored insurance, and the employers might stay in this business. I mean, that, you know, they just have a taste for, they might just have a taste for it in a way that.
Or their employees have a taste for it. The employers don't have a taste for it. They'd rather be out.
That's what I was going to say.
Their employees are willing to accept lower wages in order to get health insurance from their employers, even when there's no tax subsidy.
Right. And the other thing I was saying is they want, my experience with the employer community is they want out of this business.
They've always said they want out of this business.
So that's my concern. And if you handle the transitions that I worry about, you know, sort of in and out of different firms, in and out of different groups, in and out of the individual market, small group market, you know, then probably it's sticking around is not as big a deal. But I do worry about, you know, the sort of lock-in jobs and interruptions going from job to home back to work, all that stuff. I think those are problems with the current ESI system.
Yeah. All right, so this leads us to another set of questions then. You know, one of the things is sort of consistency in the plans, you know, kind of across those different kinds of transitions in life. There's a question from the listeners about how do you see identical networks across different insurance plans working? Isn't this the basis for plan differentiating, bargaining power, and difference in price of the plan?
I didn't suggest that because I don't think it'll
Well,
work.
I think you should offer a very low-cost network that would be acceptable, that would be the Medicaid network, and you could at least offer it in some of the other markets and see if anyone took it. I mean, especially with low-wage workers in marketplaces, conceivably, it's an attractive network. We don't know, and that's what I would suggest. So I'm not saying that I don't think the Goldman Sachs brokers are going to take the same network as the Medicaid folks, but it'd be nice if the same network were offered in several of the different markets that appeal to at least lower income workers.
So what about, the Affordable Care Act and the Medicaid provisions, focuses on the benchmark plans in the states? What about using that as
So
kind
that's
of
a
the
way
frame
to
of
do
reference?
it. Right. That would be another way to do it. But I mean, I think
that
we
gets
could
you out of the
focus-
bottom
right.
tier.
So we
you
could
think.
focus on thinking about how to encourage the same networks to be offered in multiple programs. Because from the perspective of an individual, the program is less important than the network.
Right. So maybe we have time for one last sort of set of questions about the role of the electronic health record in all of these transitions. And this, Sherry, you brought this up, the role, the
Right.
issue about,
So all of this, we haven't made as much progress as would be nice around electronic health records, and particularly around the idea of personal health records that people would own themselves and could take with them from one provider to another. In the meantime, we're really in a situation where it's wonderful to have an electronic health record, but for this population that is moving among plans and networks, that doesn't really do them very much good because their provider might change and then nobody's got the record. So what could we do around that? That seems a place where every plan has an incentive to keep its record closed, so you won't leave, right? Because that's their business model, right? So their incentive is to not let anybody else into their record. That seems like a place where government intervention might be useful.
So as a person who recently changed primary care physicians after 30 years because, I didn't feel they were paying attention to me anymore, as the previous panel addressed, it cost me, to get myself a copy of the record and a copy for my new physician, my new provider, was $50, and I don't
And
even.
it also required you to realize that you had to do it.
Right.
And probably argue with the office staff. It should be something that's very easy.
That's right. That's right. I mean, it wasn't, there was a form. I could do it online. It was fine. But it was definitely a pain. Any closing thoughts that any of you would like to offer here? The question, the closing question for the panels today seems to have been, sort of, 10 or 25 years from now, what do you hope this panel would be about, would be discussing?
Improving universal Medicare.
I think the affordability question won't go away.
Right.
And, how much can we expect different people to pay for their health insurance at different points in their lives?
And I think we're going to be wondering what's health insurance cover, because health is going to mean very different things 10, 15, 20 years from now.
So I guess that's the one concluding thought that I had after listening to all the conversations today, and we still have one more to go, is this notion of trying to educate the public that this is not one of these aspects of life or government policy that we fix at one moment in time and all will be perfect forever after and we won't have to think about it again. And it's sort of part of the reaction to some of the problems with adopting and the rollout and implementation of the Affordable Care Act and some of the implementation issues in the states. The reaction is, why isn't it perfect now? Why isn't it a plan that everyone likes and working and functioning perfectly? And I think that we, as part of our culture, have to, adopt a more sort of evolutionary sense of how these kinds of issues will, continue to be with us. Even the countries that have reached some more basic consensus about universal coverage, access to care, are still always tinkering with, various aspects of the system that they think that could be improved or to respond to different sensibilities among the population. So thanks again very much for your attention. Please join me in thanking our panelists for a very interesting conversation. I want to encourage you to fill out the blue evaluation sheets. We don't really have a break right now. Well, we have a little bit of a break. Yeah, we have about a 10-minute break till 4:30 when Susan Dentzer will moderate a discussion among former CMS administrators about the future of the Medicare program. So thanks very much.
No. I just didn't start a lecture series.
Is that okay?